Hello, my name is Maureen Madden. I'm an associate professor of pediatrics at Rutgers Robert Wood Johnson Medical School and work at Bristol Myers Squibb Children's Hospital in New Jersey. I'm here to discuss the update on the COVID-19 vaccinations for pediatric patients. It's widely agreed that an effective response to the coronavirus disease pandemic needs to include a vaccine that is safe and effective for children. However, many current vaccine trials have no plans for when to enroll children. Others have recently proposed enrolling minors as young as 12 years of age. The data on pediatric COVID-19 exists, and as of May 6, 2021, more than 3.85 million children in the United States have tested positive for COVID-19, accounting for 14% of all cases in the United States. For the week ending May 6, children were 24% of newly reported weekly COVID-19 cases in the United States. Generally, children and adolescents have a milder COVID-19 disease course as compared to adults. And the available data indicate that COVID-19 associated hospitalization and death is uncommon in children. The statistics show that children were between 0.1 to 1.9% of all child COVID-19 cases resulted in hospitalization, and children only had a reported 0.21% of all COVID-19 deaths. But yet, when you look at the 2019 statistics, looking at the top causes of death in children, COVID-19 would rank statistically in that area of the top 10. Attention has now shifted to the vulnerability of children for two reasons. First, the degree to which children transmit COVID-19 is key to how countries reopen communities after lockdown. And second, new concerns about a novel, severe Kawasaki-like disease in children related to COVID-19, which is now referred to as multisystem inflammatory syndrome in children, or MIS-C. This is the dashboard from the World Health Organization looking at the COVID-19 landscape for novel candidate vaccine developments worldwide. Currently, the number of vaccines in clinical development equal 99, where there are 184 number of vaccines in preclinical development. The current status for COVID-19 vaccines for children, which are available in the United States, have three, and they have been authorized for emergency use by the FDA. There's the Pfizer COVID-19 vaccine, which is currently available for children ages 12 years and older. There's the Moderna COVID-19 vaccine, which is available for children ages 18 years and older. And both of these vaccines consist of a two-shot regimen separated by 3 to 4 weeks interval. The third vaccine available is the Janssen or J&J COVID-19 vaccine, which is currently available for ages 18 years and older. The Food and Drug Administration of the United States originally issued an emergency use authorization on December 11, 2020 for the Pfizer COVID-19 vaccine for individuals ages 16 years of age and older. On May the 10th, 2021, the FDA expanded the EUA for the Pfizer COVID-19 vaccine to now include adolescents 12 through 15 years of age. The Pfizer vaccine has phase 3 data. The available safety data support the EUA in adolescents down to 12 years of age include 2,260 participants ages 12 through 15 years old enrolled in an ongoing randomized placebo-controlled clinical trial in the United States. Of these, 1,131 adolescent participants received the vaccine and 1,129 received a saline placebo. More than half of the participants were followed for safety for at least 2 months following the second dose. The most commonly reported side effects in the adolescent clinical trial participants, which typically lasted 1 to 3 days, were pain at the injection site, tiredness, headache, chills, muscle pain, fever, and joint pain. With the exception of pain at the injection site, more adolescents reported these side effects after the second dose than after the first dose. The side effects in adolescents were consistent with those reported in clinical trial participants 16 years of age and older. The effectiveness data to support the EUA in adolescents down to 12 years of age is based on immunogenicity and an analysis of COVID-19 cases. The immune response to the vaccine in 190 participants, 12 through 15 years of age, was compared to the immune response of 170 participants, 16 through 25 years of age. In this analysis, the immune response of adolescents was non-inferior, or at least as good as, the immune response of the older participants. An analysis of cases of COVID-19 occurring among the participants in the clinical trial, 12 through 15 years of age, 7 days after the second dose was administered, was also conducted. Among participants without evidence of prior infection with COVID-19, no cases of COVID-19 occurred among the 1,005 vaccine recipients, and 16 cases of COVID-19 occurred among 978 placebo recipients. Therefore, the vaccine was considered 100% effective in preventing COVID-19. This cross-sectional survey was evaluating caregiver willingness to vaccinate their children against COVID-19. The method was an international cross-sectional survey of 1,541 caregivers arriving with their children at 16 pediatric emergency departments across 6 countries and was conducted between March 26th and May the 31st of 2020. The results found that 65% of the caregivers reported they intended to vaccinate their child once the vaccine is available. 62% reported the reason intending to vaccinate was to protect their child, and 52% those refusing vaccination was related to the vaccine's novelty. The COVID-19 pediatric study conducted by Pfizer is a clinical trial that opened May 2021. The intention is to have 4,644 children enrolled worldwide, ages 6 months to 12 years. The age groups consist of 6 months to 2 years, 2 years to 5 years, and 5 years to 12 years of age. The methods will be 2/3 of the participants will receive the COVID-19 study vaccine, while 1/3 of the participants will receive a placebo. 6 months after the injection, all participants will be disclosed if they receive the vaccine versus the placebo, and at that point in time, all who receive the placebo will have the option to receive the study vaccine. The Moderna pediatric COVID-19 vaccine trial began in March 2021. Called the Kid Cove study, it's a phase 2 and 3 vaccine trial. The enrollment is approximately 6,750 children between the ages of 6 months and 11 years in the United States and Canada, and the trial is broken into 2 parts. Part 1, there's a different dose of the vaccine that are being tested. For ages 6 months to 1 year, there will be 2 doses at either 25, 50, or 100 microgram level. Ages 2 to 11 years will be 2 doses at either the 50 or 100 microgram level. Part 2 consists of findings from Part 1, which will inform which dose to be used. The findings of Part 1 will also be used in Part 2 to expand to include children who are given a saline placebo, and the children in Part 2 will be followed for 12 months after their second injection. We know that children are different, and the current pandemic of severe acute respiratory syndrome with the COVID-19 virus reveals a peculiar trend of milder disease and lower case fatality in children compared with adults. Consistent epidemiologic evidence of reduced severity of infection in children across different populations and countries suggests that there are underlying biological differences between children and adults that mediate different disease pathogenesis. So risk factors for severe disease. Pediatric patients with severe or critical disease tend to have other underlying medical problems. There are few reports of severe or critical disease in infected immunocompromised patients. There seems to be some level of protective immunity. We know that infants mount higher magnitude immune responses to protein vaccines like HPV and hepatitis B as compared with adults, indicating the potential for early life immunization for lifelong protection. Currently, there are several hypotheses about why children may have milder disease than adults. Host factors such as cell entry enzymes are differentially expressed in infants as compared with adults. Different magnitudes of aberrant immune responses in infant lung tissues as compared with adults. And children are more likely to develop cross-protective immune responses as compared with adults. So as vaccine development has ramped up and been rolled out, the questions have started to become about mandatory vaccination, in particular whether mandatory vaccination for children should be in place. So using the case of measles vaccination, looking at measles, the reproductive number, which means the number of others to whom an infected person would spread the disease if placed in a totally susceptible population, is very high, around 15. With this background, approximately 92 to 94% of the population must be immune in order to prevent spread. This has been achieved by requiring 2 doses of measles vaccine for children in all United States before enrolling in school, with only very limited ways to opt out. Looking at other diseases such as influenza virus, the reproductive number is only around 1, and looking at the SARS-CoV-2 virus, it's a little bit higher at 2 to 2.5. So therefore, this makes a question about whether vaccinating may reduce the risk of spread, especially among at-risk subjects. Investigation has also been ongoing looking at the potential cross-reactive immunity to the COVID-19 virus from common human pathogens and vaccines. This study has looked at the proteomes of 25 human pathogens and in-vaccine antigens. The intention was to exploring the potential role of cross-reactive immunity acquired from pediatric vaccinations and exposure to common human pathogens. The results found that pediatric vaccination against viruses do not contain cross-reactive epitopes, precluding any general protection against COVID-19. But common viruses, including rhinovirus, respiratory syncytial virus, influenza virus, and several of the herpes viruses, are also poor or null sources of cross-reactive immunity to the COVID-19 virus, discarding that immunological memory against these viruses can have any general protective or pathological role in COVID-19. But it was found that combination vaccines, such as the diphtheria, tetanus, and pertussis, or DPT vaccine, to be a significant source of potential cross-reactive immunity to the COVID-19 virus. So children may be protected through the immunity elicited by the DPT vaccination, as they have 3 to 4 doses of during the first year of life, and again at 4 to 6 years of age. When looking at the pediatric population, there is a significant importance associated with the pediatric vaccines, predominantly because children are more likely to be asymptomatic or have milder symptoms of the COVID-19 virus. Therefore, they're less likely to present to healthcare and less likely to be tested for the COVID-19 virus. Oftentimes, some of the symptoms are associated with common viruses in the pediatric population that are seen routinely. There's also a potential direct benefit for prevention of disease in children. There's a substantial indirect benefit through community protection or herd immunity. And as recently as May the 12th, the American Association of Pediatrics, or the AAP policy statement came out that the COVID-19 vaccine can be administered at the same time or within 14 days of other vaccines, with no need to discreetly separate them or to wait. So this is a change in recommendations from prior discussion. So in summary, since nearly a quarter of the U.S. population is under 18 years of age, and the percentage is significantly higher in many other countries, effective herd immunity will require pediatric vaccination. Vaccinating children is likely to have benefits both direct, protecting children against rare, severe pediatric cases of COVID-19 and post-infectious conditions such as multisystem inflammatory syndrome in children, or MIS-C, as well as indirect benefits such as protecting others by reducing the spread. Those indirect benefits also have social and economic impact, looking at potentially reduction in family toll of parental illness, an impact on the failing economies that can get back up and functioning in the more routine manner, as well as the chronic stress associated with the concern of having COVID-19 or the sequelae of it.